Let's get started on today's presentation. I am Alicia Gonzalez. I am the Clinical Training Director for California Bridge Program. Good to be back here with a good friend, a mentor, and frankly, just like an amazing person that I have gotten to work with, Dr. Daniele Feldman. She's an OBGYN, but she also is fellowship trained in maternal fetal medicine. So she specializes in high-risk pregnancy. She is the upcoming Chief of Staff at Marion Regional Medical Center. Holler, holler to all of our Central Coast, California people out there. And it is really just a giant privilege for me to invite her to be our guest speaker today to talk about this buprenorphine in pregnancy, demystifying the fear. I know that this is a huge topic for us. A lot of times we get questions about it. So we're hoping to myth bust a bunch of concerns you might have. California Bridge is a program at Public Health Institute. We are funded by the Department of Healthcare Services. We are a nonprofit organization, and none of our speakers, Dr. Feldman and myself, we don't have any financial disclosures. If we use brand names during this presentation, for example, referring to buprenorphine as, say, Suboxone, which is one brand name of bup plus naloxone, that is simply because our patients often call it that and not because we have any financial interest in using that. Here is what we are going to talk about today. It's going to be jam-packed, so much information. Get excited. Put your questions in the chat as we go. If you're watching this live, we will address them at the end. We're going to talk a little bit about generally substance use disorder in pregnancy and in the peripartum period. So women who've just had a baby as well, postpartum. We're going to talk about doing medication for addiction treatment in pregnancy, saving both mom and baby's life. It's safe. I'm excited to talk about that in detail. We've got lots of ethical and legal considerations, lots of questions that come up about mandatory reporting, drug testing. So we'll deep dive into that. And then we want to talk about effective screening and engagement strategies for helping pregnant patients who use drugs, as well as always, one of our favorite topics, harm reduction. Let's frame all of this with a patient, just to give us some content. And this could be a patient that you see in an ER. It could be a patient who presents, to your clinic. It could be anything. So hopefully it's a little bit universal for us. But this is Maria. She's a 28-year-old female. She has regular alcohol, tobacco, and fentanyl use, sometimes meth, but that's not really her drug of choice. She missed her period and had a positive pregnancy test at home. Immediately, even though it was not a planned pregnancy, it's a wanted pregnancy. So she immediately cut out the alcohol and methamphetamine use, but she's having a really hard time quitting the fentanyl because the withdrawals are really intense for her. So she's been continuing to use opioids because of that. She comes in and she's saying, this is a wanted pregnancy, but it's a surprise. She's so afraid of going to the hospital because she hears from everyone, they're going to take my baby away. They're going to report me to Child Protective or Child Welfare Services, and they take your baby away. That's what happens. So she's really terrified of getting prenatal care. She's really terrified of going to the hospital. She tried going to the ED 2 days ago because she was withdrawing really bad, but they weren't super nice to her. They made her wait a really long time. They were busy. All of us ER people know that life. We're really busy treating emergencies. We don't always recognize that this is an emergency. She's in the lobby for a couple hours and got so sick, she just could not handle it. It was hell feeling like that. And so she had to leave. This is a real patient. A lot of real patients, but it's definitely a real patient. And so we want to think about Maria as we go through today. And these are the questions that at the end, I'm going to ask Dr. Feldman to answer for us. But how would we approach this case? What is our treatment strategy? What are the priorities? There's a lot going on for this patient. We don't have 4 hours to sit with her and figure out the best things. What are our obligations as clinical care providers, as navigators, as nurses, as social workers? What legally and ethically, what are our obligations in this case in general? Do you have to report her? Is she right that we take babies away? And so I will hand it over now to Dr. Feldman to tell us why this is even a topic we should talk about, and we'll go forward from there. Dr. Feldman.
Thank you. Thank you, Dr. Gonzalez. I'm so excited to be here. So we'll just jump right into it. So substance use disorder is a significant problem in pregnancy, and we're going to be focusing here today on opiate use disorder. But generally speaking, 21,000 pregnant women misuse opioids every month. These numbers are likely underreported, and also some of these data are from pre-pandemic times, and we've definitely seen an uptick with COVID, a much higher use of opioids and other substances, and also overdose. But we'll just the numbers that we have here are pre-pandemic, so they're a little bit underestimated. 6.4% of pregnant women ages 15 to 44 use illicit substances. So that's sort of generally speaking, 1 in 20 pregnant women are using illicit substances. And then if you narrow it down to teenagers, so 15 to 17, age 15 to 17, 14.6% of pregnant teenagers are using illicit substances. So this is a really significant slice of the population. And we'll go into a little bit later in the talk about how we find these patients, because for reasons that Alicia alluded to, people are not necessarily reporting this for fear of taking babies away and whatnot. But these are the numbers that we have, at least for generally speaking. Between 2000 and 2009, the prevalence of opiate use in women who gave birth increased significantly from 1.2 to 5.6 per thousand births. And as I mentioned, this is a low ball estimate compared to the numbers that we're seeing now. In terms of mortality, so maternal mortality, generally speaking, in the world of OBGYN and just socially, we're very aware that in the United States, we are very much behind and really doing poorly in terms of global health. We're doing very poorly in terms of maternal mortality. And when we say maternal mortality, we're talking about pregnancy and also in the postpartum period. And overdose mortality is a very significant cause of maternal death. So it's second only to, so it rose very significantly between 2017 and 2020 from 6.5 to 11.8 per 100,000 pregnant women. And as I mentioned, it's even higher now. And the increase was 81% in pregnant and postpartum women. And to just emphasize the scope of this problem, more women die from opiate overdose in pregnancy or related to pregnancy than do from hemorrhage, preeclampsia, or infection. And that's very specifically a US problem. In other parts of the world, this is not happening, but here, very, very, very high rates of mortality, specifically from opiate use. In this graph here, you can see, so on the left, the types of drugs that we're talking about have sort of changed over time. So with the yellow dots, that represents fentanyl and other synthetic forms of opiates. And we've seen a significant uptake in use of synthetic opiates, even over the last several years. As well as some others here. And then on the right, just looking at, generally speaking, when maternal deaths occur related to opiate use and overdose, it's significantly increased in the postpartum, the early postpartum period, and also the late postpartum period. So most pregnant women, especially pregnant women who are able to access medication-assisted therapy, do relatively well during pregnancy, but it's in that postpartum period that really women are at risk in the most vulnerable time period. And then this also just emphasizes that. And so overdose rates per 100,000 person days. And if you see in here, so we have for patients who are just all opiate use disorder events, for people on pharmacotherapy and people off pharmacotherapy, it's significantly elevated in the later postpartum period, even for women on pharmacotherapy. Opiate use disorder is an OBGYN problem. So a lot of people, and especially OBGYNs, I don't know how many are out here, but we tend to think of our kind of world and reproductive health, but opiate use disorder is a significant part of that and affects so many people that we take care of. Specific to OBGYN, there's a significant history of stigma against mothers who use drugs. And again, going back to the patient that we talked about, the fear of having a baby taken away is a really significant thing and affects all sorts of ways that women view, women who use substances, view healthcare providers, view the system, fear of accessing care. It's a really significant barrier. Fear of losing custody of their kids, and also, and again, leads to low rates of access to addiction care and MAT for pregnant and postpartum patients. The good news is that medication works. And so medication for addiction treatment or medication for opiate use disorder, medication-assisted therapy, I'm going to be using the word MAT from here on out, but it definitely works, and we'll talk a bit about that. So most people here are probably familiar with this concept. So when people first start using opiates, the goal or the effect goes from a state of feeling normal, whatever that may be for somebody, to feeling a state of euphoria. And as time moves forward and as the use continues, that state of euphoria, the effect of that diminishes until a person uses opiates just to feel normal. And so it goes from a state of withdrawal to a state of feeling normal. The goal of opiate agonist therapy is to maintain that normalcy. It's to maintain that normal feeling without the continued use of illicit substances. MAT saves lives. So this is generally speaking for 5-year mortality risk in the general population. So for people who are getting MAT, the risk of death is 1.8 times the general population as compared to 6.1 with no treatment. In terms of numbers needed to treat, and so just if we think about other areas of healthcare and other interventions that we do to address issues, so aspirin for ST elevation MI, you would need 42 to save a life, steroids for COPD, 10 to prevent treatment failure, to defibrillation and cardiac arrest, it's 2.5 to save a life. And for buprenorphine and opioid use disorder, it's 2 to retain in treatment. So it's a significant bang for your buck in terms of successful treatment for patients with this disorder. There's a lot of just in general, there's a lot of concern about safety of various medications, and since methadone, buprenorphine are opiates, there can be a lot of concern as to whether it's safe in pregnancy, but it is. And not only is it safe in pregnancy, but it's a standard of care, and we'll see that in a minute. But generally, the goal of MAT in pregnancy is to avoid the cycle of intoxication and withdrawal for mom and fetus. It lowers the risk of overdose, also lowers the risk of death from overdose, improves maternal weight gain and nutrition, and lowers rates of IV drug use, lower risk of infection, also lower risk of at-risk behavior in various social contexts. This is an ACOG committee opinion in collaboration with the American Society of Addiction Medicine, addressing opioid use disorder and treatment for it. And the bottom line is that medication-assisted therapy, or MAT, is safe. Opioid agonist pharmacotherapy is the recommended therapy. And so this is it's an important thing. And actually, I would say even more for patients, because if somebody is on opioids and is pregnant, the first thing, this is a conversation that I have with patients all the time who really want to be on nothing and who really want to withdraw and just be off of opioids entirely. And it's a really important message to convey that the standard of care is medication therapy for various reasons that we'll go into. So for medically supervised withdrawal, and like I said, I get this question constantly for patients who come see me for a consult, or who come even not for a consult, and who are on methadone or buprenorphine, or even still using whatever opioids they're using. They'll ask if they can come off of their medication or of their drugs just because they're afraid of babies taken away and neonatal withdrawal and whatnot. But it's an important message to tell them that this is not the standard of care. And the reason for this is multifactorial. One of the big ones is that there's an extremely high rate of relapse and return to use, upwards of 90%. And this can be for multiple reasons. Pregnant women, generally speaking, not just for this, but pregnant women can be it's a vulnerable population, both during pregnancy and especially in the postpartum period. There's a significantly increased risk for maternal overdose, and particularly, again, death from overdose if somebody stops using and then starts using again. Patients maintained on MAT have higher rates of follow-up with the same provider, and so access to healthcare is significantly improved. And generally, there are poorer outcomes for mom with tapered withdrawal, and especially with significantly higher risk of relapse. Here are some medications used for opioid use disorder. I think most people here are familiar with this. But when we're talking about MAT, we're talking about methadone and buprenorphine. Naltrexone is also something that's used in very special circumstances. It's generally not been quite as well studied in pregnancy. But in rare circumstances, you can have patients on naltrexone. For the most part, methadone has been used for decades and is very well studied, very well understood. Buprenorphine is a little bit newer, but lots of emerging data and more recent data supports it significantly. But the methadone and buprenorphine are the main players here. With methadone, it's most often an oral solution where patients need to typically go and get this at a treatment facility. Buprenorphine exists in sublingual, IV, and IM forms and is available on an outpatient basis. So buprenorphine specifically, and this graph actually shows just a comparison between the three medications. So buprenorphine treats withdrawal, cravings, and overdose. It's a partial agonist as compared to both methadone and also morphine and fentanyl, which are full mu agonists. Buprenorphine has a very high affinity for the mu receptor. It blocks and displaces other opioids and can precipitate withdrawal. The half-life for bup is about 24 to 36 hours. It's long-acting. This can be different in pregnancy, by the way, and particularly in the latter part of pregnancy where the half-life can be significantly shortened. That's especially true for methadone, but also for buprenorphine, which can lead to needing to split doses and whatnot. That's kind of a detail, but important to know. One of the important factors to consider with buprenorphine is this ceiling effect. And so whereas with methadone, you can increase doses to have very high, up to even in the 500s, 600s on certain occasions. For buprenorphine, there is a ceiling effect. And so this can have an impact on patient selection of who's a good candidate for buprenorphine, but that's one of the important factors to consider. Buprenorphine is safe. It decreases maternal morbidity and mortality risk. It's safe to start in the ED or the hospital or the outpatient setting. This is generally true for some patients, especially in the latter part of the third trimester, starting on buprenorphine or sometimes switching from methadone to buprenorphine, which we'll do at times in the third trimester. A lot of people do opt to do this in the hospital unless it's posing a barrier to the care, but it is possible just in general to start this medication on an outpatient basis. People will often refer to buprenorphine as Suboxone or Subutex. And as Alicia mentioned in the beginning, Subutex is a brand name for just the mono product of buprenorphine. Suboxone, which is what most people call it, is actually buprenorphine plus naloxone. And the goal for that is to prevent diversion, where chopping it up and selling it on the street will not give the same effect. And so that's the reason that naloxone exists in there. But the medication, the actual chemical that we're interested in is the buprenorphine. And again, methadone and buprenorphine are both safe and approved for all 3 trimesters of pregnancy and also during breastfeeding. Buprenorphine is safe for the baby. So people will always ask, and we know that for women on any sort of opiate, there is a risk of neonatal abstinence syndrome or neonatal opiate withdrawal syndrome. Buprenorphine reduces the risk of NAS compared to illicit drug use. The risk and severity of neonatal abstinence is not correlated with MAT dose. Now, this is generally true. There's a little bit of controversy over this, particularly with methadone. There are some older data to suggest that there was no association, and I know this slide says buprenorphine. Right now I'm talking about methadone. There's some older data to suggest that there's no association with dose. There's some newer data to suggest that, especially with significantly higher doses of methadone in particular, that neonatal abstinence is more severe. That whole thing is actually confounded by newer ways that we address neonatal abstinence in the hospital. So newer protocols that are meant to promote shorter length of stay, less use of IV morphine in neonates. And so there's a lot of moving parts to this. But generally speaking, the bottom line, I think even if there is a small increased risk of the severity of neonatal abstinence, whether you're talking about buprenorphine or methadone or if there's not, the goal is not to lower the amount that you're giving somebody, because the whole purpose of the medication is to allow people to not have cravings, allow people to maintain their abstinence from illicit drug use and control the opiate use for a whole number of other reasons. And so generally speaking, this should not be a reason to try to cut back on dose. As far as the use of any of the MAT, it's even safer for baby when it allows for mom to be involved in the postnatal care, including rooming in, skin to skin, breastfeeding, which all reduce the incidence and severity of neonatal abstinence. This is data from one of the big sort of landmark trials looking at substance, the comparison of buprenorphine to methadone for pregnancy. This was a randomized trial, aptly named the Mother Trial, published in the New England Journal at this point more than a decade ago. And it was randomized. There were only 175 patients, which is not a very high N, but even so, the general outcome of the trial showed that with methadone as compared to buprenorphine, there were lower lengths of stay for bup, duration of withdrawal was lower for bup, and need for, there were a lot of offshoots of this trial, but generally this particular trial favored buprenorphine over methadone as far as baby factors. I'm going to turn it over to Alicia to talk about the quick start in pregnancy, and particularly with the California Bridge algorithm and guidelines.
Thank you. Yeah, so I want to get down to the details a little bit of just how do we actually start a patient on buprenorphine. And I'm seeing a bunch of questions come up in the chat, which don't worry, I'm addressing them a little bit as we go, but also we'll get to some at the end. But the gist of this is like, there are so many myths. I'm even seeing them in your questions, right? Like, well, what about fentanyl? I can't use bup and fentanyl. We have to use methadone. Or what about the ceiling effect of buprenorphine? It can't go high enough. And so hopefully walking through this protocol will help to reassure you that actually bup is really safe. And again, this is not a lecture to promote buprenorphine over methadone necessarily. Some patients will do better with one or the other. But buprenorphine, for logistical reasons, is much easier for us to start in the emergency department, and can be easier for mom in the sense that she doesn't have to go to a clinic every single day. She can have a prescription that goes home with her. It's really easy for her to adjust the dose on her own as she gets further along in her pregnancy, and then go to her doctor and say, hey, I'm in my 3rd trimester. I feel like I'm needing a little bit more buprenorphine as my body mass goes up. And those things are just practically speaking easier. And so we prefer buprenorphine also for that ceiling effect, decreased risk of overdose because it doesn't cause respiratory depression, and because we know it has lower rates of neonatal abstinence syndrome, or NOWS, the opioid withdrawal syndrome in neonates. So all that to say, here's how you do it. This is a link to the quick start guide in pregnancy. If you're watching it live, it's also in the chat, but we're going to walk through it very, very briefly. If you've ever started a patient on buprenorphine, this is going to feel so familiar because it's the same. That's the surprise, exciting piece of information. It's not different. You can start a pregnant patient on bup the same way that you can start a non-pregnant patient on bup. And I really, really want to emphasize this. We see so many cases where people are terrified of giving mom big normal buprenorphine doses. Please don't be afraid, okay? 2 and 4 milligram and little bitty doses don't really help people feel better. So give those normal doses that you're used to giving. To help prevent precipitated withdrawal, we want to make sure the patient is in moderate to severe withdrawal. If you're not familiar with what that looks like, no big deal. You can use COWS, the Clinical Opioid Withdrawal Scale. Make sure their score is at least 8 or higher. If the patient uses fentanyl, you're definitely going to want to make sure you're also seeing objective findings. And frankly, in 2023, fentanyl is everywhere. So patients who are using heroin selectively are probably being exposed to fentanyl without realizing it. So we definitely recommend looking for some of those objective findings. Do they have the goosebumps? Are they vomiting? Are they sweaty? Are they tachycardic? Fast heart rates? Look for those kinds of things. You want to make sure that you're ruling out some of those complicating factors. A patient who comes in altered or in medical distress, let's say she is here for preeclampsia, or she's here for abruption, or she was in a car accident, maybe not the right time to approach starting buprenorphine, right? These are for patients who otherwise are not in a medical emergency. Treat the emergency, treat mom's pain. Don't worry about it in that context. We do want to screen for methadone because if somebody has used methadone in the past 72 hours, we don't want to give buprenorphine because we can precipitate withdrawal. Screening for methadone doesn't mean you're in toxicology screening. It just means ask, do you use methadone? Is there any chance you've had methadone? Because I really don't want to hurt you by giving you this medicine. And it's important for me to know that, right? It's a non-stigma based question. Make sure we're just verbally screening it. I mentioned this, but I'm going to say it again. They need to be in moderate to severe withdrawal, a score of 8 or higher on cows. If you're a trained clinician, you know what it looks like. You already know what it looks like. You don't need a cows, but moderate to severe withdrawal with objective findings or hard signs. At that point, you're going to give a dissolvable oral dose of buprenorphine, 8 to 16 milligrams. I will remind you that it's an oral dissolvable medicine. It does not work the same way as, like, for example, ondansetron or Zofran. If you swallow Zofran, it works the same as if you let it dissolve in the mouth. That's not true with Bupe. Bupe has a different bioavailability, so we need to let it dissolve in the mouth. My recommendation, let mom or let the patient get some water first, wet their mouth. If they're vomiting, they can spit it back out, but just wet mouth is easier to dissolve medications. Take that medicine, nothing to eat or drink for 15 to 20 minutes to allow that to fully dissolve and absorb so that the medication will work. Remember, fentanyl is really widespread. I'm still seeing questions pop up in the chat about it. That's a reasonable thing to ask about. Don't be afraid to go with a higher dose. So one mistake we see a lot is that people freak out about fentanyl. So they either say, we have to use methadone, or they say, I have to use little doses of buprenorphine and go slow. The opposite is true. Buprenorphine is very safe in fentanyl, but go high. Give 16 or 24 milligrams up front if your patient self-discloses a heavy use pattern. You're not sure what that means? Ask. Patients are really good at telling you. They know when they are a heavier use pattern patient or a more mild or moderate use patient. You can also just ask them how much. And if your patient is saying things in grams, that's one way to know that it's a very high usage pattern. It's kind of a quick and dirty. There's no perfect graph that tells you how much Bupe for how much fentanyl, illicit fentanyl. That doesn't really exist. But you can certainly believe that at higher doses of fentanyl that they're using on their own, they can go much higher in their doses of buprenorphine. And remember, there's a ceiling effect on respiratory depression. There is not a ceiling effect on treatment of withdrawal. I'm going to say that again. There's a ceiling effect on respiratory depression. There is not a ceiling effect or maximum dosage for treating opioid use disorder or opioid withdrawal with buprenorphine. So that is a common misnomer. Like, there's a ceiling effect, so I have to use methadone in a high use pattern. False. You can totally use Bupe and just go higher. Don't be afraid of going higher. Remember that patients in their third trimester are bigger, and we know that opioids disperse themselves in our fatty tissue. So it's very common for patients to need higher doses. If you're starting a patient on buprenorphine in her third trimester, I recommend starting with at least 16 milligrams, and don't be afraid again of those 24 or 32 milligram doses. And if you're ever not sure, I'll give you some numbers at the end of people that you can call to help you. It's also common for a patient who's already on buprenorphine, as Dr. Feldman said earlier, to need to go up on their doses during that third trimester. That does happen. We'll talk more about that in a minute. Remember to screen for methadone. It is okay if mom is using alcohol or benzodiazepines or other respiratory depressants. It's still okay to start buprenorphine. It's just something that you want to monitor a little bit more closely. That doesn't mean admit inpatient monitoring. It just means maybe not in the ER lobby. So if the patient doesn't use any respiratory depressants, they can safely start Bupe. If you don't have a bed, that's okay. But if maybe they also use alcohol or alprazolam, Xanax, those kinds of things, maybe you want them on a pulse ox just to make sure that this goes safely for them over the next couple of hours. Emphasizing this again because we see this mistake made a lot. You do not have to admit a pregnant patient, even in the second or third trimester. You do not have to admit her to the hospital to induce her on medication for addiction treatment. You really don't. It's safe to do in the outpatient setting. It's safe to do from the emergency department. So please don't add barriers and costs that don't exist to our patients. We can totally do it upfront, NBD, no big deal. Okay, then you're going to wait about 45 minutes to an hour, reassess your patient. If they're getting better, give another dose. We want all of our patients to get to 16 milligrams that first day. So if you start with 8, give another 8 an hour later. If you went higher, you may or may not need to duplicate that dose or give another 8 milligrams to get a full loading dose in their system. Most patients will do really well with a total of about 16 milligrams, an 8 and then an 8. But patients with a higher usage pattern or who are mostly selectively using fentanyl will need higher doses. If your patient's not better at all, take a step back. Are you missing something? Does she have COVID? Does she have a viral illness? Does she have sepsis? Does she have preeclampsia? Like, make sure that you're not missing something, because pure opioid withdrawal responds to buprenorphine, period. But most common reason a patient doesn't respond is that you didn't give enough. So another argument here for please don't give tiny baby doses of buprenorphine. You have to saturate enough of those mu or opioid receptors to actually make them feel better. So if you gave an 8 milligram dose and a woman is far along in pregnancy, or they have a high usage pattern and they're slowly getting worse, you probably just didn't give enough. That's not to be confused with precipitated withdrawal. Precipitated withdrawal is when somebody has full agonist opioid in their system, which with fentanyl can take longer for them to metabolize out because it does disperse into adipose tissue. So that's why you're looking for objective findings of withdrawal to make sure you're really ready to start bupe. But precipitated withdrawal is you give bupe and they instantly get sicker. What does that look like? Naloxone. It looks like when a person had an overdose, you gave naloxone and they abruptly wake up. That is a rapid, significant, sudden clinical worsening. It's not the same thing as when you give mom a little bupe, not enough, and then she's getting sicker and continues to withdraw over time. Not the same thing. So most of the time we see undertreated withdrawal. We don't see precipitated withdrawal that often. And if you do precipitate withdrawal, it's not unsafe, it's just uncomfortable. So be ready to treat it. And the answer is more buprenorphine. Once you've given some bupe, that you've kicked off some of that full agonist and occupied it with your partial agonist, you now need to give enough to fully saturate those receptors with your partial agonist. So we have this all in our protocol. I won't deep dive right now. The point is, don't be afraid of it. And the mainstay of treatment in that scenario is more buprenorphine. So you'll notice that I keep saying more buprenorphine, higher doses. I'm never saying low baby doses. That's usually how people find themselves getting into trouble or causing unnecessary pain for their patient. At the time of discharge, no matter how much it took to get your patient feeling better, most patients will do well with a take-home prescription that totals about 16 milligrams a day. So that can be 8 twice a day. Maybe if they were a higher usage pattern, they might need 8 3 times a day. As Dr. Feldman noted, later in pregnancy, it's more common to do better with split dosing. So not all at once, but to take it as a 2 or 3 times a day dose. But generally speaking, somewhere between 16 and 32 milligrams total daily dosing divided into 2 or 3 times a day is good for everybody. And how many films or how many tablets do you write? Enough to get them to follow-up care, and then a buffer, because patients get their appointments canceled. They can't make it for transportation. Like, it's way safer for mom and baby to stay on the medication than to run out of their prescription and head into withdrawal and then need to use fentanyl. That really increases their risk of overdose. So make sure the patient has enough medication. We could talk about diversion maybe later during the Q&A, but I don't want you to be worried about that. You'll notice I didn't mention the X waiver. It doesn't exist anymore. If you had one, you don't have one anymore. They literally erased them. There is not a doctor in this country with a DEA license that is not allowed to do this. That is one of the difference between this and methadone. So we like buprenorphine because every single clinician can do it. Every PA or nurse practitioner with a DEA license that includes, controlled, scheduled substances can give buprenorphine for medication for addiction treatment immediately. And if you forgot everything or you need help in the moment, however complicated or simple the case, you can, in California, you can call poison control 24/7 and ask for help or advice. And if you are in California or also outside of California, but it's more business hours or banker hours, you can call the consultation center warm line to get a hold of an expert that's based out of San Francisco. They can be really helpful. So I recommend filing these as things that you don't forget. So a quick recap: make sure your patient's in withdrawal. Do not be afraid of a higher dose. Start with 8 or 16 milligrams. If the patient has a very heavy use pattern, you can even go higher than that. Make sure they're feeling better in about an hour, 45 minutes to an hour. And if you gave an 8 milligram dose as your first dose, give another 8 to get to at least 16. If you didn't get any better, did you undertreat them? First of all, do they need much higher doses, or are you missing a medical emergency? That's the time to stop and think about that. And then at discharge, give them enough medication to get to their outpatient follow-up. Most patients will do great with somewhere between 16 and 32 milligrams a day, kind of depending on how heavy their usage pattern is. So that's how to start it. And now we're entering one of the areas where we get so many questions. So I'm going to kick it back over to Dr. Feldman. I started a patient on bupe. Maybe she's doing great her whole pregnancy. I'm so excited. And now this is the part where it feels like everything falls apart. This patient comes in labor. What happens? If you're an OBGYN, labor and delivery team, nursing, doctors, whatever, how do we handle this moment for this patient?
Thank you. That was an amazing overview. Thank you, Alicia. So when somebody comes in for labor, so one of the common, I think one of the most common confusions or things that we see is trying to use somebody's maintenance therapy as pain treatment, but it's not. So the most important thing is to continue the patient on their buprenorphine or methadone if they're on methadone at the dose that they're at. Now, sometimes people need a little, I mean, sometimes you'll see folks go up on a maintenance dose, but the goal of that is not to treat pain. It's only to allow the baseline state to be more stable. With anesthesia in particular, and this well, in general, for patients with substance use disorder, opioid use disorder on medication, it's really important to approach patients in a multidisciplinary fashion. And so this involves the OB, of course, maternal fetal medicine, especially hopefully a maternal fetal medicine person in your area who has specific knowledge in this area, and also anesthesia. Very important to have anesthesia on board. And what we'll often do is have anesthesia come and do a little consult with the patient when they first come in labor, if there's time for that. Regional anesthesia, there's no interaction, no effect with opiate agonist therapy and anesthesia with either regional anesthesia or local anesthesia. So really maximizing that. The other thing that is a common misconception is that for somebody on methadone or buprenorphine that they can't be given additional opioids, and that's not true. And so it is entirely okay to give folks additional morphine or whatever, whatever extra opioid they might need for pain control. This is even true in labor. Which generally for patients not on opioid therapy, we do try to avoid that, especially close to delivery, as it can cause some respiratory suppression in baby, but that is a viable option. PCEAs are a viable option. And also importantly, post-delivery to continue buprenorphine. And again, sometimes at even higher doses, again, not to maintain therapy or not for pain control, but just to maintain therapy. And I think there are two important factors that contribute that you kind of have to keep in the back of your mind when treating patients who are on MAT in labor and post-delivery for pain control. And that is that tolerance is higher and also pain thresholds are lower. So both of those things in mind, keeping both of those things in mind with treatments is important. I know I've been talking a lot about methadone throughout my talk, and generally methadone for MAT is also effective, life-saving. Methadone versus buprenorphine, there are a lot of factors that need to go into this in order to make this decision, and this can be local availability. Insurance, especially in our area, is a really big deal because for our area, at least for a long time, there were very few providers who would take people's insurance who were prescribing buprenorphine. Now with the waiving of the X waiver, it's a little bit less of a deal, but that also comes into play. And patient preference, and some people have had experience with one medication or the other, or they know of so-and-so who've had one experience with one thing or the other, and they want one. And it's not, I think that we as providers should not be trying to steer somebody in a direction or another, especially if they have a particular preference. What the ceiling effect is also an issue. That is absolutely fine. Buprenorphine is absolutely fine, even for somebody who's on fentanyl. The general conversion, somebody who's requiring more than roughly 140 milligrams of methadone, might not do as well on buprenorphine, but that's kind of a not set in stone rule, but that's kind of a number to keep in mind. Methadone can, as we saw earlier from the mother trial, can be associated with lower birth weight, can be associated with more severe neonatal abstinence. But again, those things are kind of in flux, and especially with some of the newer methods to address neonatal abstinence with Eat, Sleep, Console, that's less just even with methadone or with buprenorphine. We've talked a couple times about increasing doses and split dosing in the third trimester. This also can be a really big barrier to methadone, because if somebody is having to go twice a day to get their methadone dose, it's just not feasible for most people. And there are some methadone clinics that will be willing to give folks their evening dose, but not all. And so that also might be a reason to not do methadone for somebody. For after delivery, so as we saw earlier, the postpartum period is the highest risk for patients in terms of depression, relapse, mental health issues that come up postpartum. There's also it's this double whammy, because while patients with opiate use disorder can have an increased risk of adverse events in pregnancy, women with adverse events in pregnancy, especially adverse delivery and kind of peripartum events, are at increased risk of developing substance use disorder moving forward. And so it's just really, really important to be mindful of this and to keep your postpartum patients close. If somebody misses an appointment, call them, get them to come to their appointment. It's a really vulnerable time period. These patients should absolutely continue on their mat, start working on the follow-up plan before delivery. And this, I talked about this interdisciplinary team. Social work's really important. Mental health care providers are really important. Psychiatry is really important. Lots of comorbidity with mental health issues. And so making sure that people have a plan in place for postpartum. I will say that this is also one of the barriers to a lot of OBGYNs or even maternal fetal medicine people starting patients on buprenorphine, because that follow-up care can be disrupted, because we often have people for their pregnancy period and don't necessarily have that more long-term relationship. And so making sure that people have a viable plan and providers that they can reliably work with long-term. And then just a note here about higher doses of buprenorphine to allow that kind of baseline state, and can taper down if it's feasible or necessary. For breastfeeding, it's strongly recommended for patients on MAT. So not only is it okay, but patients really should breastfeed if they can. Of course, if there are no other contraindications or other barriers, breastfeeding is hard. And so if it's just, if it's not feasible, this is not something we want to be adding for people to feel guilty about. However, it is really helpful, and especially with the role of mom and role of breastfeeding in neonatal abstinence care, and particularly with Eat, Sleep, Console, that it's really, the goal is not, so we've kind of shifted away from giving babies with withdrawal symptoms morphine, and the goal is not to give them no morphine, but to just give them less medication. And breastfeeding is extremely helpful for that, both for the consoling kind of factor, and also for the very small amounts of opioids that are in breast milk. And so it should be very strongly supported. Yeah, so right, and I mean, again, if there are no contraindications, so heavy alcohol use or other illicit drug use, sometimes breastfeeding is not feasible, but when it is, support it as much as possible. I want to take a minute to talk about screening for substance use disorders. And so we've talked about what we do for patients with opiate use disorder. But how do we find these patients? I mean, most people are not coming into the office or even the ER, where a lot of pregnancies are diagnosed in the ER. But people are not coming in saying, oh, by the way, I use fentanyl, and what are we going to do about this? And so it's really, really important, and this particular slide is geared largely for outpatient settings, to do universal screening. So all pregnant women should be screened for substance use disorder. This should be a standard part of the initial intake. And I would say also, even in, like I said, in the ER, if there's, if this is a feasible thing for when people come in with a diagnosis of pregnancy, if it's possible. This needs to be universal. There's a very long history of selectively screening people based on whatever predetermined bias that folks have toward certain populations of patients, and this is not acceptable, and screening needs to be universal for every single person who walks through your door. Early screening is important, so as I said, the very first visit. There are lots of validated screening tools. So very importantly, when I say screening, this is with a validated verbal tool. This is not urine screening. Also, a lot of A lot of places, even still now, actually, even in our own area, a lot of places still use urine drug screen as the screening method of choice. There are many reasons why this is not okay. But the good news is that there are many validated tools, the NIDA-4, 4Ps, plus the CRAFT, which is more geared toward teenagers, but still usable. There's also the DAST. I mean, there are multiple screening tools available. I don't know that one is particularly better than the other. I think the important thing is for an institution to just choose one and adopt it and use it. And they're all validated and used in pregnancy. And so the goal is to administer this to everybody. If somebody screens positive on whatever tool you're using, the SBIRT theory to apply. And so it's screening, which we talked about, and a brief intervention, and then a referral for treatment. And I'm not going to go a ton into this because, again, this is mostly an outpatient OBGYN kind of clinic setting thing that really needs to be implemented. But the point is to just screen for substance use disorder, and if that includes opiate use disorder, and involve the patient and open a dialogue about the response and come up with some plan for referral for treatment, and so that people can access the care that they need. Very, very important to maintain patient-centered screening. And I want to back up for just a minute and just emphasize, I think most people on this call hopefully have the mindset that use of substances and substance use disorder, opiate use disorder, it's a disease. It's a disease just like any other disease that you would think of, like diabetes or thyroid disease or whatever it is. And it's not a moral shortcoming. And I think that it's impossible, and we have a slide in a minute, but it's impossible to talk about treating patients with opiate use disorder or substance use disorder without talking about bias. And bias can mean lots of different things, but in particular, and I'm sure everybody here has witnessed this in one way or another, there's a lot of just frankly meanness in terms of treating patients with these disorders, and we need to move away from that. And one of the ways to move away from that is to focus on the patient and have the care be patient-centered, including the screening. And so motivational interviewing, that's kind of also something that could be its own talk. But the point is to build a rapport with your patient, to cover the pros and cons of use, to ask permission to give feedback, to assess a patient's readiness to change, and to write down an action plan for change, and generally to approach this whole relationship with an open mind and ask to learn and explore. And you will get very far with this mindset. Going on a little bit more about this, it's really important to meet patients where they're at and to get on the same page, to normalize what the conversation is. So many of my patients use drugs like fentanyl. Is it okay if I ask you about these things? Acknowledge what somebody is going through, and acknowledge that it's a difficult thing to discuss. Align your goals with the patient's goals, and to ask and empathetically explore instead of assume. And also just to trauma-informed care is also a really important part of this, and we could have a whole talk specifically dedicated to that. But to just really remember that this doesn't happen in a vacuum, that people have lives and histories, and drug use often stems from significant trauma history, and to just be informed about that and be mindful about that. And that also helps to lead to a mindset of radical acceptance, that you're going to meet somebody where they're at and not include or invite any, or as much as possible, not invite bias and judgment, and just treat the patient for the disease that they have, just like you would any other. Again, like I said, stigma and discrimination, and this again also by itself could be its own topic in the history of stigma and discrimination and bias in reproductive health care, and specifically with various populations. But one of the ways to help just kind of build into your rapport with people is to use person-first language. And so words really, really matter. And the words that we use and the words that we engage our patients with are really important. And so some examples of this are, instead instead of saying the word he is bipolar, say he has a diagnosis of bipolar disorder, and so on and so forth. In terms of how we address patients who use substances, patients themselves might use words like junkie or kind of self-deprecating language. Even the word like getting clean, like patients will say, I'm getting clean, implying that they weren't before. So patients can say that themselves, and actually often as a reflection of how people feel about themselves, which, low self-esteem and self-worth, and that's an important piece. But we should not be using those words when talking to people or when talking about patients, even with our colleagues. Just avoid it entirely. I mentioned this a minute ago, but just a quick note about urine drug screens. So like I said, a lot of clinics and a lot of offices and places will use urine drug screen as a way to screen for substance use disorder, and we just should not, for many reasons. There's a very high potential for false positives and for false negatives. So somebody who has a substance use disorder won't necessarily test positive on a urine drug screen, maybe because they haven't used in a day or two, maybe because they use something that doesn't show up. There are some labs where some of the synthetic opioids don't necessarily show up. And so that is not, and on the false positive side of things, somebody might test positive, but that doesn't mean that they have a substance use disorder. There's a very long history, again, of bias and selectively ordering urine drug screens on people. And so it increases the risk for inequities, which we should be doing everything we can to avoid. Also, the results don't assess parenting capabilities. So it's not because somebody tests positive that it's going to necessarily mean that they're unfit to be a parent. As I already mentioned, that's often selectively applied. And in California in particular, I know we have some people on or some people listening from other states, but in California in particular, this should not be ordered routinely or as a standard, and you absolutely have to get the patient's consent. Now, this can be a verbal consent, but you can't just have somebody hit the floor and order a drug screen without asking them if it's okay. This is back to the committee opinion. So I actually was part of an ACOG. We had this big NIH grant to spread the word in California for our section, for our California district of ACOG, to kind of spread the word about not using urine drug screens and using universal verbal screening tools. And so this is supported by our national societies. And this is from this committee opinion: the drug enforcement policies that deter women from seeking prenatal care are contrary to the welfare of the mother and the fetus. So incarceration and the threat of incarceration have proved to be ineffective in reducing the incidence of alcohol or drug abuse, and really do, just to my own completion of that sentence, it really does prevent people from getting the care that they need, which is the antithesis of what we're trying to do. Now, there are times where a urine drug screen or a urine drug test can be helpful and can be important for somebody who's already in treatment. It can be an important part of that. And in fact, with methadone, it's actually required for with some degree of regular urine drug testing for somebody. And this is more of an ER thing. We in labor and delivery, fortunately, don't find too many attended patients, but this could be a good reason to get a test to make sure that there's not that's not the cause of the clinical presentation. Also to evaluate mimics. And again, this is, I think, more geared to an ED population, but even so, if there are other things that a patient is exhibiting, it's important to have that in the background. Now, again, I will say that asking the patient the question is going to be your best bet. If somebody does come in and has tics or itching, or in our world, hypertension or abruption, asking a patient, have you used any substances, and having kind of a formalized, validated way that you do that is going to be more effective than the urine drug screen. But also reasonable to say, do you mind, is it okay with you if we order this drug test to help you and make sure we're taking the best care of you that we can? And as I mentioned here in peripartum, so patients coming in with an abruption, preterm labor, hypertension, these are all things that are very commonly seen in patients who overuse particularly stimulants. And so in that patient population for our labor and delivery world. It's a reasonable subset of the population to order urine drug tests. But again, just to go back to the original point of talking about urine testing in the first place, this is not for screening. In this scenario, it's because you have a particular clinical question that you're trying to answer. You're not trying to find who uses substances, who has a substance use disorder. This is in the context of a particular clinical scenario. So legal considerations. This is going to be, I'm in California. I can speak to California. This is a very tricky and sensitive subject. As far as California law, however, there is a ton of misconception out there about, even in our own state, about what the requirements are in terms of reporting for women who use substances and for babies who are in withdrawal. The California Penal Code very specifically does not say that women who screen positive for any kind of substance use need to be reported to CPS. It does say that it requires an evaluation. And so legally speaking, if you know that somebody has a history of substance use, it should trigger an evaluation, working closely with your social workers to make sure that that happens. And then based on that evaluation, if there's a concern for the child's safety, then that can be reported. But the use of drugs alone or the identification of somebody who uses substances alone is not a reason to report. There is a federal law, the Child Abuse Prevention and Treatment Act, CAPTA. This was amended in 2016. There's a little bit of nuance here. With the CAPTA laws, it does kind of kick it back to states. There is a requirement to develop a plan of safe care. However, what that really means is not clearly laid out. And it also doesn't say who needs to do that and how. It's just kind of this general requirement. It does seem to be that there's a requirement of some kind of report that there is substance use, but not that it's child abuse. Now, this is different by state. So I am speaking for California, and working really closely with your social workers, really working really closely with resources, and just kind of approaching to, having a general mindset that generally keeping families together is better than separating them, and really distinguishing, at least in California, we have the benefit of not having maternal substance use be by definition child abuse. Now, that's not true in other states. So you just have to know what your rules are in your states, because 25 states and the District of Columbia do consider substance use during pregnancy to be child abuse. So this is a really important kind of legal matter. And I do encourage people, if there's any question about any of this, to even contact. I mean, most institutions have legal experts who can help you navigate this system. And as I have mentioned, just to remember that addiction is not a moral failing. It's a chronic disease that requires medical treatment and help.
But let's start with this patient we presented at the very beginning, right? Remember Maria? So she was that 28-year-old female. She had polysubstance use, found out she was pregnant, wants to keep that baby, was able to stop using alcohol and methamphetamines, but has really been struggling to quit her fentanyl use because the withdrawals are so hard. And she attempted to come to the emergency department for help, and it didn't go so great the first time, and here we are. So Dr. Feldman, I would ask you, like, putting kind of all of it together, let's say this patient comes to you in your clinic, she's like, hi, I'm pregnant, I had a home pregnancy test, this is my scenario. How do you approach that patient encounter, knowing that you can't do all 50,000 things you want to do for her in maybe a 20-minute visit in your clinic?
So the most important thing is opening a conversation with her, opening a dialogue with her about what she's willing to do, what she's able to do. Have you heard of MAT before? Have you ever tried it before? And opening that conversation and starting it, starting the bupe right there. And then if that's what she wants, or if she has any particular leaning toward methadone, referring for that. But not wasting time is an important thing to kind of get going, especially for somebody who's captive and in the clinic. And also to having a set go-to list of resources for patients, because it's not enough for just one provider to just write a prescription. You really need to have social support and other resources in place for patients. And so just referring to your pre-made up method of doing that and appropriately referring people.
Yeah. So, and I just want to emphasize for anybody that if you see this patient in the ED, start her on MAT, start her on buprenorphine, start her on buprenorphine. Don't be afraid. Don't be afraid. Don't be afraid. And if you are afraid, call us and we'll be here to help you. I'm going to mention a couple of quick concepts on harm reduction. So remember that harm reduction is a really, really, really big area. It's not just naloxone, although we love naloxone. I'm going to mention it in a second, but there are lots of things you want to make sure, like if you have a mother who isn't willing to, quit illicit drugs and doesn't want to be on MAT, there's still things you can do for her. You can talk to her about, sterile syringe access and disposal programs to at least just decrease the risk of HIV and hepatitis and endocarditis and all those other things. There are a lot of movements towards like housing first. Can you address mom's food insecurity, her housing insecurity? Maybe she's in a relationship that is not safe for her, that is maybe leading to some of her inability to stay, away from the drugs that she doesn't want to use. Who knows? But to remember that there are lots of ways to help decrease harm for patients that aren't simply quitting the use of illicit drugs. That is a really unfun concept to think about, that some patients will continue to use illicit drugs despite being pregnant. But remember, addiction is a chronic medical problem. It is a physiological change, a neurocognitive change. They're not doing it because they're bad people or bad parents. It's a change in their body that makes things a lot more complicated. And if you have not started a naloxone distribution program from your emergency department or your clinic, check out our guide to naloxone distribution to help you do that. It's free in California, which is awesome. And some other states have a similar thing, but please check it out. Get this naloxone life-saving treatment for mom and baby in the case of overdose into everybody's hands. And now we're going to apply it to a couple of more patients. We're almost done. So let's talk about case number 2. This is Padma. Padma, by the way, all of these are real patients that I have gotten phone calls on. And so I'm bringing them now to Dr. Feldman to make sure I did the right thing. But we obviously changed a couple of the identification information so you won't know who they are. But if you're somebody who called me about this patient, you might recognize this story. But it's a 30-year-old female. She's 22 weeks pregnant. She has a history of daily heroin use. I will say that at some point she tested positive for fentanyl, so probably contaminated, but heroin is her drug of choice. She's currently taking methadone twice a day. She actually came in with a complicated urine infection. So she was admitted to the hospital for her pyelonephritis. And on rounds, she asked the clinician, the OB, I want to switch off methadone to buprenorphine. I heard it's better for my baby. Everyone's been giving me a bad time. The nurses keep telling me this is true. The nurses were kind of giving her a bad time for being on methadone. There's a lot of stigma attached to it. And even though she's been doing great on methadone, she hasn't had a relapse. Her pregnancy's been going well. She feels this pressure to change. How would you address that conversation?
Well, the most important thing is to, again, meet her where she is and to just reassure her that methadone is a perfectly safe and viable option. So for somebody who's doing really well on any maintenance therapy, typically I don't switch them off of it to change to buprenorphine. While there's some evidence that bup might help with certain neonatal outcomes, it's not enough. It's not enough of a reason, I think, and most folks would agree, to switch someone and all of the risks that come with that, like precipitated withdrawal, which can really suck. And also challenging, especially if somebody's doing well and able to maintain compliance and able to do the methadone, to switch it to a brand new thing, which sort of rocking the boat kind of concept. Now, that being said, for people who are really motivated to switch to buprenorphine from methadone, is completely viable and possible. Often we do this in the hospital, just to allow for management of withdrawal symptoms, and especially for somebody who's a little further in pregnancy. But we can also do that too, and there are ways that it's actually pretty similar to just starting bup induction in general. But really having the conversation with the patient of where this desire is coming from, and also just making sure that you're really applauding her efforts and giving the positive feedback that what she's been doing up until this point is really great and really helpful and the right thing for her and her baby.
Yeah. So anecdotally, I will tell you, I know a lot of our teams out there, there's just this weird stigma that is attached to being on methadone as opposed to being on buprenorphine for your MAT. So what I'm hearing as the take home message is like, if a patient's doing well, and reassure them. And if they really, really are motivated to switch, there's a comment in the chat like, well, what if they don't want to go to the clinic every day anymore? Reasonable. It's possible. Maybe get your maternal fetal medicine, specialist involved to do that cross tapering. It's possible, but find out why. Why is the motivation to switch coming? And if they're doing well, instead, maybe some reassurance and encouragement is the right thing.
Mm-hmm.
All right. Case number 3, last case for today. This is a 24-year-old female. She is pregnant. She is 32 weeks gestation. She is a person who has used fentanyl daily in the past. She came into the emergency department 24 hours ago in pretty florid withdrawal. What really happened in real life with this patient is that the emergency department doctor didn't feel comfortable because of how far along in pregnancy this patient was. So they called the OBGYN. They also had a hospital policy that anything later than 22 weeks, which is a common policy, that it goes to labor and delivery triage first. This person kind of came to the ED on their own, but so they called OB. The OB team admitted to the labor and delivery unit to start the patient on supervised buprenorphine induction. But the team was unfamiliar. The general OBGYN physician and the nursing staff and the nursing manager actually was adamant that we could not give high doses. So they had given the patient 2 milligrams of buprenorphine 3 times, each 4 hours apart. So it's now been 12 hours and the patient's only received 6 total milligrams despite a heavy fentanyl use pattern at home. The charge nurse's main claim for why they couldn't is that they were telling everyone, including the patient navigator, there's a huge risk of seizure, that we're going to make the patient seize if we give her high buprenorphine. There was a genuine concern for this. The patient's doing terribly. She's in horrible withdrawal. She's getting worse. She's getting worse. She wants to leave. So the bedside nurse, who did a urine toxicology screen that they didn't ask the patient about, but she didn't have great prenatal care. They did that screening, already called child welfare services, who is sending an individual to the hospital. So we're in a nightmare scenario. This woman is in horrible withdrawal, which has been undertreated. Everyone trying to take care of her, who I'm going to give them the benefit of the doubt, is trying to do the right thing, but doesn't know the right thing. They're scared to give her more medication, and CPS is on the way. How, if they call you, somebody calls you, Dr. Feldman, what do we do? How would you handle this case?
Give more.
Yeah.
Yeah. I mean, and we've talked about this a lot. So not being afraid to give higher doses of bup. And that's obviously what she needed. And also, the calling CPS is
Yeah. So
dramatic.
this really did happen. And what I learned in being the person that got this phone call was, I think to your point, the most immediate thing is you have to just be firm with the advice, which is you need to give more. Give a high dose now. What I actually recommended was 32. I was just so concerned about CPS being on the way. I didn't want to waste. I went very high. I'm not recommending everybody be comfortable with that, but I'm comfortable with that. And so I did it and it worked great. And thankfully, by the time the CPS worker showed up, actually everything was fine, which was kind of a miracle. But after that, I felt the work wasn't done. And so we reached out to that OBGYN department and talked about, can we do an in-service for your nursing staff? And the reason I bring this up is I don't want to fault anyone, nurses, clinicians who are uncomfortable, but the onus on us as champions, those of you watching this lecture, if you have not taken the time to do education with your department, please do. Your nurses, your techs, your unit clerk, your navigator might not know all the things that maybe you didn't know coming into this lecture. So this is the beginning of the ripple. You need to be the ripple. Please take this to your team. If you want, the slides, reach out to us if you need help, info@cabridge.org. And remember, Matt saves lives, and it is on us to bring this life-saving treatment to our patients and to help relieve their pain and suffering. So it does save life, both for mom and for the baby. So if you really want a patient using drugs to do better with their pregnancy, put them on medication for addiction treatment. Both methadone and buprenorphine are safe in the both in the actual pregnancy period, but also postpartum. Remember the huge risk of overdose and death postpartum. We don't want to drop those patients. The delivery is not the end of this journey. We all need to work to do a better job connecting our postpartum moms to ongoing care, and not just for that first one-time visit, right? For at least a year, double checking it. Get rid of barriers. No more universal screening and things that add stigma. No need for admission or monitoring. Start with high enough good doses, treat the patient, let them go home on their buprenorphine or connected to methadone treatment if that's what's best for them. Don't be afraid to continue their bup. Do not stop it during labor. You'll make their pain so hard to control. They'll go into withdrawal and it'll be so much worse. But don't be afraid to treat that labor pain. Get that epidural in if they want one. Don't be afraid to give morphine or fentanyl on top of the buprenorphine. The patient is in the most monitored setting she's ever going to be in her life. So give her the medications, make her feel better. And remember, universal screening, not urine screening, but actual substance use screening. Talk to your patients, assess if they have an illicit drug use pattern, and offer them the treatments that they need to stay healthy and well. And if you forgot everything, all of that meaty content, please head to our California Bridge resources page. You can go to bridgetotreatment.org. Everything is there for you. Full library of resources, including, we did not deep dive into this, but we have an entire document about trauma-informed care in pregnancy. So I would say for you as a champion, your action items from here, please go share this information with your teams so we can all do better. And then for yourself, when you're ready to take on more, dive a little bit into what trauma-informed care is. It's a really helpful way to just meet patients where they're at, thinking about radical acceptance and the journey that leads, a woman using drugs in pregnancy to be where she is, and helps us just be better care providers for that person. I want to mention the American College of Obstetrics and Gynecology. Dr. Feldman and I both referred to them a couple of times. This is, the national leading organization in all things OBGYN. Their policy statements are so wonderful and evidence-based, and they are a collaborative group of experts that set that standard. Please feel free to go there, look at those policy statements, print them out, share them with your teams to use them for that dialogue. They are considered the gold standard as far as opinions and clinical expertise in OBGYN. So we really appreciate the work they've done, and I want to encourage you to go to their website. And before we take questions, I want to offer huge thanks to you, Dr. Feldman, for being here. Your expertise knows no bounds, and your passion for taking care of all patients to make their pregnancy healthier and their lives better is just so amazing and inspirational to me. I want to thank the people whose names are on the screen who also gave us a bunch of information and helped me put together the content for this lecture. Obviously to ACOG, I already sung their praises, but I just appreciate the work that organization does. All of our California Bridge team and all of you who took the time to learn this information. If we did not address what you want, info@cabridge.org, info@cabridge.org. Ask your question. We'll funnel you to the right expert to get you what you need. And I will pause here to see if anybody has any more questions. Let me grab that chat here. All right. Oh, several people actually asked about neonatal abstinence syndrome, or now is the neonatal opioid withdrawal scale. Do you have preferential references that you use? Like, what's the most up-to-date guideline for how to treat those neonates in the NICU? Do you have any recommendations for where to get that information?
Oh, that's an excellent question. So that's not what I do.
Right. Yeah.
We have, so in our own institution, we developed our own policy for that. And by we, I mean our NICU directors and our NICU team, of course, in collaboration with us as the people who take care of moms. But I know that they pulled from various evidence-based guidelines. I don't know that there's one in particular. There might be, and if there is, and I'm not saying it, I'm sorry, but we have at our own hospital, and for Common Spirit, we have our eat, sleep, consult. And this is actually relatively new. I mean, it's within the last several years, actually. So the whole approach to neonatal abstinence has really changed in the last 5 to 10 years or so.
Yeah. Awesome. I would say, to the point of American College of Obstetrics and Gynecology, there are also national colleges in medicine for pediatrics and for neonatology. And whenever I'm looking for something specific, I go to that college. They almost always have something helpful for things that are really common. So I would recommend looking for the American Academy of Peds and just see if they have links to things. I would trust them. Just like I trust ACOG to be the expert on OBGYN stuff, I would trust them for that. All right, there were a couple, I know we already addressed some of this, but I'm going to bring it up one more time, which is that people said, are you sure it's safe to give buprenorphine to a patient that uses fentanyl? Like, is it going to work? Is it safe? Am I going to precipitate withdrawal? There still were some comments about fear. Is there anything else you want to say about that?
No, it's safe.
You heard it here, first and last, definitively safe.
Mm-hmm.
Excellent. And then really, I think we addressed all the other questions that came up. Yeah, we have somebody in the content saying it's safe. Yes, thank you, Sabrina. Take home message. Awesome. So I want to say thank you again to Dr. Feldman. Thank you to all of you for being here. Any questions we did not answer, info@cabridge.org, info@cabridge.org. We will make the slides and the link to this video accessible to you if you want to keep learning in the future. And thank you so much for everything that you will do to help us better care for women who are using drugs in pregnancy and for all patients who have substance use disorder. Thanks.
Thanks for having me.